Hi team. I'm thinking by now you're probably used to my YouTube videos, but this one is super important in my heart and in the practice that we have and really utilizes why MANA exists and what our main goal is. So today we're going to talk about high risk patient management in a SNF or a long-term care setting, including the assessment, the intervention, and collaboration to prevent return to hospitalization. So today's discussion focuses on how we manage high-risk patients in the SNF and long-term care settings, and how early assessment, timely intervention, and effective collaboration can prevent many of our avoidable hospitalizations. Preventing rehospitalization is not about avoiding the hospital at all costs. For many of our patients, hospitalization itself carries significant risk, including delirium, functional decline, medication complications, infections, and disruption of care continuity. As nurse practitioners in the SNF, we care for medically complex, often frail patients who may not tolerate repeated transitions well. Our role is to recognize risk early, intervene appropriately in the facility when it's safe to do so, and escalate care thoughtfully when needed. This presentation will walk through how to identify high-risk residents, recognize early warning signs, use facility-level treatment options effectively, collaborate across disciplines, and ensure safe, informed transitions when hospital transfer becomes necessary. This goal is intentional, proactive, clinically decision-make that supports patient safety, continuity of care, and high quality outcomes. So before we talk about interventions, we need to be clear on who we're worried about the most. These are the residents who tend to quietly decompensate and end up hospitalized if we don't intervene early. High risk isn't defined by one diagnosis. It's usually cumulative. The more of these indicators a resident has, the higher likelihood of a clinical decline. What's important here is that many of these indicators are stable. They're often changes from baseline rather than dramatic events. These criteria are meant to prompt closer attention, not immediate transfer. They help us decide who needs earlier assessment, tighter monitoring, and proactive intervention. Identifying high-risk residents early gives us the opportunity to assess, intervene, and stabilize them in the facility before deterioration occurs. Early warning signs are not a reason to transfer. They are a reason to act early so that transfer doesn't become necessary. Most residents don't usually crash. They declare themselves quietly through intake changes, confusion, respiratory drift, and subtle vital sign trends. If we wait for dramatic changes, we've often missed the window where intervention is most effective. What's important here is not any significant finding, it's the pattern. A resident with slightly reduced intake, increased PRN use, and mild confusion is far higher risk than any one of those findings alone. These early warning signs are cumulative and trend-based, and they require us to pause, reassess, and escalate care early. Early escalation at this stage means focused assessment, targeted workup, and early intervention, not calling EMS. This is where we prevent deterioration rather than react to it. If a resident is unstable or unsafe to remain in the facility, transfer is always appropriate. I need to make that clear. But many hospitalizations occur not because the patient couldn't be managed in the SNF, but because these early warning signs weren't acted on in time. This is one of the most important mindset shifts for practice in the skilled nursing facility. Escalation is a clinical action, not a transport decision. When we escalate, we're increasing the level of clinical attention, nurse practitioner evaluation, targeted workup, early intervention, and close monitoring. We are not automatically calling EMS. Escalating early is not overreacting. It's how we buy ourselves time to intervene and stabilize the patient in the facility. Hospital transfer should happen because it is clinically necessary, not because early warning signs weren't addressed. In the SNF, we can do as much of what the hospital does at the front end, such as labs, imaging, IV fluids, antibiotics, medication adjustments, and frequent assessment. Using those tools early often prevents deterioration. Now that we've clarified what escalation really means, let's talk about treatment options we can initiate in our facility once we escalate. So clinical decision-making in the SNF follows a progression from early intervention to stabilization to transfer only when necessary. Each tier represents increasing intensity of care, not urgency to transfer. Before we go into the details of each tier, I want you to understand how we think about treatment decisions in the SNF. We don't jump from symptoms to transfer. We move through tiers of intervention while the patient is still stable. Each tier represents increasing clinical intensity, not increasing urgency to send the patient out. Interact supports this process, but the clinical thinking happens here. At the end of the slideshow, I'm going to attach the Interact Decisions algorithm for acute mental status change, change in behavior, dehydration, fall, fever, GI symptoms, heart failure, lower respiratory infection, shortness of breath, and UTI. These walk us through what the nurses should be asking for, but in actuality, we should be responding by asking the questions from the care path, as well as doing the workup. What is suggested? Do you have to follow all of these? No, but this is evidence-based practice. So for this care path, shortness of breath, the nurse would be calling and letting you know that the patient is short of breath. They also should have the vital signs. If they don't, this is your cue to ask them what the vital signs are. So if you have any vital signs that are abnormal, you're going to react to them. Decreased O2 sats means starting on oxygen. An increase in fever means starting Tylenol. There are a lot of vital signs they should be giving us that will identify and alert us to an easy, simple treatment of care. And so the nurses are, again, in blue. They're going to evaluate symptoms. But if they don't, ask the question. So this one is shortness of breath. You're going to ask if they have a cough. Ask if they have abnormal lung sounds. Ask if they have a change in mental status. If you are on site in the facility, this is where you would go in and assess to see if the patient has a cough, if the patient has abnormal lung sounds, if the patient has changes in mental status, if they haven't been sleeping well or eating well because of their shortness of breath. Do they have a new irregular heart rate? Do they have cardiovascular, respiratory, or symptoms that suggest sepsis? Again, all point toward us, the MD, the nurse practitioner, and the PA. But again, if we are in the facility, we should be assessing the patient. And if we are not, we should be asking these questions. So this is for the nurses to ask you these questions. This is for us to initiate. So maybe we need a portable chest x-ray. Maybe we need blood work, a CBC, a CMP. This says BMP. I like the CMPs better. But are we looking for an elevated white blood cell count? An EKG if they're having pain or palpitations, spirometry, COVID test, influenza, even RSV tests at this point. Are we putting on oxygen? Are we doing an SVN, whether it's duoneb or albuterol? Are we giving them a breathing treatment? Are we listening to see if they have bronchitis and they have wheezing and they need some steroids? So some of the tests that would be ordered, if they ended up with an abnormal chest x-ray, we would potentially start antibiotics or determine if they've got a pleural effusion, if we've got elevated white blood cell count, if you've got critical labs in your blood count, or if your EKG shows significant arrhythmia or signs of a heart attack. Now remember, we're not reading the EKG. We're ordering an EKG with results. And so that would give us the results there. And those would be stat. Again, we're ordering them. That is where nursing and the DON is so very important to get these tests done. So what are we managing in the facility? We're managing oxygen, vital signs, medication. So if they've got congestive heart failure and they've got 2+ JVD and they've got 4+ bilateral lower extremities, do they need a diuretic? We're going to get a pro-BNP if we're assuming that it's congestive heart failure to verify and validate what we're doing. Do we need to get respiratory therapy involved? Many facilities have respiratory therapy. If they're there on site, have them evaluate. Make sure that their influenza or pneumonia or COVID vaccines are up to date. If you've got pneumonia going around the facility and this patient didn't take a pneumonia vaccine, it's highly likely that this would be a differential that you would want to consider. And then vital signs. So if they do end up resulting in improved symptoms, then we can just continue to follow them. But I will send these for all of those diagnoses that I just spoke of. Not only should the nurses be asking, but this is what we should be asking if we're at home, and if we're in the facility, we should be doing the assessment, working these patients up, and ordering the labs as necessary. Many of the steps we're talking about align with the Interact tool, but the goal isn't the form. The goal is the clinical thinking behind it. So tier 1 is where we intervene early while the patient still has physiologic reserve and before instability develops. The goal of tier 1 is not to try to solve everything immediately. The goal is to identify the problem, initiate appropriate treatment, and to buy us some time to evaluate the patient's response. Tier 1 starts with a nurse practitioner focus assessment, not a full head to toe, but an assessment targeted to the presenting concern and change from baseline. Understanding what is new versus what is not new or chronic guides us to the next step. Labs and imaging should be targeted, not reflexive. We order what helps answer the clinical question we're trying to solve and avoid unnecessary testing. Medication adjustments, hydration, electrolyte support, pain and constipation management, and oxygen titration are often enough to stabilize patients when started early. Small, timely adjustments can prevent larger problems later. Tier 1 always includes clear nursing monitoring parameters and a defined reassessment timeframe. An intervention without a plan to reassess is incomplete care. A common error is assuming tier 1 has failed before it's had time to work. Early intervention followed by reassessment is what prevents escalation. If the patient stabilizes, we continue the plan. If not, we move into Tier 2 with enhanced monitoring and adjustment. Tier 2 is the most critical and most underutilized phase of care in the SNF. This is where many hospitalizations are either prevented or triggered. Tier 2 begins with the patient has received initial interventions but requires closer observation to determine whether they are stabilizing or continuing to decline. This is not passive monitoring. Tier 2 is active clinical surveillance. Unlike Tier 1, which focuses on initiating treatment, Tier 2 focuses on evaluating the patient's response to treatment. So let me just throw in the question that is burning on all of your hearts. If you have a Medicaid or Medicaid pending patient, you see them for the emergency. That is correct. Would you follow them on day 2? No, this is when you tap in the medical director and tell him what has been initiated and ask him to follow the patient the following day. This is very critical that not only did we do Tier 1, but we're monitoring Tier 2. So increasing monitoring frequency, trend vitals, intake output, labs and reassessment, and making real-time adjustments is responding. Tier 2 is where interdisciplinary support becomes essential. Therapy, nutrition, wound care, and nursing feedback often provide the earliest indicators of improvement or decline. And never forget your first-line staff. Communication with the medical director at this stage strengthens decision-making and helps avoid uncommon transfer. A common mistake is assuming that if the patient hasn't improved immediately, transfer is required. Tier 2 gives us the opportunity to stabilize patients who simply need time, adjustment, or closer monitoring. Tier 2 is a decision point. Either the patient stabilizes and remains in the facility, or they demonstrate they cannot be safely managed here, and they move to Tier 3. When Tier 2 is done well, transfer decisions are clearer, safer, and more appropriate. By the time we reach Tier 3, we've already assessed the patient and initiated appropriate Tier 1 and Tier 2 interventions when indicated. Tier 3 escalation occurs when the patient has not stabilized or cannot be safely managed within the facility. This includes failure to respond to earlier interventions, hemodynamic or respiratory instability, new neurological deficits or declining mental status, or the need for diagnostic or treatments that aren't available in the SNF setting. At this point, hospital transfer is appropriate and necessary. This is not a failure of care. It reflects sound clinical judgment and patient-centered decision-making. Equally important is how we send the patient out. A clear clinical handoff to the emergency department, not just calling 911, can make the difference in patient care. Communicating what changed from baseline, what workup has already been completed, what interventions were attempted, and why transfer is occurring helps the receiving provider quickly understand the clinical picture and continue care without unnecessary delays or duplication. The assumption is you reporting to 911 or EMS what's going on with the patient translates into a report given to the hospital, and that is not accurate. You must make contact with the hospital and give them a full report so that they're aware of what we have already done to try to prevent rehospitalization. When transfers occur after a thorough and thoughtful assessment, escalation process, and clear handoff, the transition is safer, more efficient, and ultimately in the best interest of the patient. Preventing hospitalizations is never a solo effort. It requires clear roles, communication, and shared responsibility across the team. I never want you to think that you calling 911 is 100% on you. Your role is to assess the patient, initiate appropriate workup and treatment, and then reassess the response. Escalation at this level is about increasing clinical attention, not transferring care. Nursing plays a critical role by monitoring trends, recognizing early changes from baseline, and notifying the provider early. Execution of the care plan and timely communication are what allow interventions to work. The DON supports this process operationally, ensuring appropriate staffing, monitoring escalation patterns, and helping remove barriers so that care plans can be carried out safely and consistently. The medical director provides consultation and support for complex cases, involving them early when needed strengthens decision-making and helps avoid unnecessary transfers. Clear escalation pathways are meant to support timely action, not create delays. Collaboration should move care forward, not slow it down. When everyone understands their role and communicates early, we're able to intervene sooner, stabilize patients in the facility, and make better decisions about why hospital transfer is truly necessary. This is where many avoidable hospitalizations actually occur, not because the initial plan was wrong, but because the patient was not reassessed. Anytime we change a medication, respond to a new symptom, or initiate antibiotics or fluids, we are obligated to reassess the patient, typically within 24 to 48 hours. In the SNF, patients often look stable immediately after an intervention. Deterioration usually happens hours to days later, especially in older adults with limited physiologic reserve. Reassessment allows us to confirm that the intervention is working or recognize that it is not. Reassessment only works if nursing knows exactly what to report back. That includes changes in vitals from baseline, intake and output, mental status, pain, respiratory effect, and functional ability. Clear expectations prevent missed signals. Reassessment is not just a check-in. It is an opportunity to adjust the plan based on the patient's response. If the patient is improving, we continue. If they are not, we escalate care, not location. The most common pathway to rehospitalization is a set it and forget it approach, where an intervention is ordered, but the response is never reassessed. When reassessment is built into the plan, we intervene earlier, stabilize patients in the facility, and make more informed decisions about escalation or transfer. When transfer becomes necessary, it should be a clinical decision, not a reflex response to uncertainty or time pressure. A well-timed transfer is part of good care. The goal is not to avoid the hospital, but to ensure that when we do send a patient out, it's for the right reason and with the right information. A clear handoff to the emergency department is critical. At a minimum, the handoff should explain what the patient's baseline is, what has changed, what workup has already been completed, what interventions were attempted, and why is the patient transferring now. This context allows the receiving provider to quickly understand the clinical picture and continue care without unnecessary delays. We've talked about this earlier in our slides. This is one of the most critical parts of transferring a patient to the hospital. 911 is not the handoff. The handoff is not to EMS. The handoff is the clinical communication that explains the story behind the transfer. Clearer communication improves patient outcomes, supports continuity of care, and strengthens collaboration. So high-risk patient management in the SNF is about early recognition, timely intervention, and thoughtful collaboration. As nurse practitioners in the SNF, we are uniquely positioned to recognize that risk, intervene proactively, and stabilize patients in the facility when it is safe to do so. Hospital transfer remains an important tool, but it should be the last step, not the first. Thank you for taking time to review this material. I know you're busy, but this information is very important. If you have any questions or need clarification, my contact information is included. Thank you and have a great day.